Good afternoon, ladies and gentlemen. I'm not certain if I'm supposed to start, but it's actually 2 minutes past 2 o'clock, and I think I'm supposed to start at 2 o'clock, so I think I do that. It looks like I should have been introduced by someone, but I don't really need that. I am TULLUS. I live in London and I work at Great Ormond Street Hospital for Children. But as you can hear from my accent, I'm not really English, but Swedish. And for those of you who want to, you will have to listen to me too long today. And I'm going to talk about 3 of my really favorite topics, quite different topics: lupus nephritis, nephrotic syndrome, and urinary tract infections. So I'm going to start with lupus nephritis. And actually, this room is very strange. I really feel like in a tennis match. And I think that it's a high chance that you who sit over there will be sort of ignored by me. I apologize for that, because I like to point on the screen. And I actually plan to point on this screen. So if you want to, you could move over to this side. I don't think we will be more people then you will have plenty of space here. But it's up to you where you want to sit. But I plan to point to this one. And I'm sort of a moving object as I move around. So I might move away from the microphone. So if you don't hear me, scream, okay? Let's start with lupus nephritis. As I said, I'm Swedish, so I like this, of course. But that's not the only reason I show this one. The main reason I show this slide is actually, if you look here, 11 cases published, 5 had nephritis, and at time of publication, 6 were dead. So this is just to emphasize, of course, which we all know, that lupus and lupus nephritis are very severe diseases that without treatment have a substantially bad outcome. How do children with lupus present? Well, we all know it's a multi-organ systemic disease. And you can see here, virtually every organ system is involved. And in children, where the disease is worse than in adults, then a big majority have constitutional symptoms like malaise, weight loss, growth retardation. Many have a rash, a malar rash. Most have hematological abnormalities. Regarding nephritis, you can get as many different percentages as studies. I think 84%, which was in this study where I took it from, is wrong. But I think it's something like 50% of children will have a significant nephritis. What do you see otherwise? Well, many, perhaps even more than 50%, have anemia, leukopenia, thrombocytopenia. This is interesting to remember, that most of them, virtually all of them, have high ESRs. In contrast to, for example, a vasculitic child, they do not have raised CRP. So if you have a lupus child with raised CRP, then some of them could have a serositis, but you have really to suspect an infection related to the lupus. So lupus do not normally have raised CRP. Virtually all have raised double-stranded DNA, perhaps not each and every, but absolutely the big majority. More than 75%, big majority have raised double-stranded DNA. And most have, of course, low complement, low C3. And as I said, you can get different percentages, but I think something like 50–60% is a true percentage, all depending on how you define. And it is more common and it's more severe in children compared in adults. And I think that's important to remember, because a lot of lupus nephritis children that are looked after by general pediatricians, for example, in collaboration with adult rheumatologists. And when I see that happening, most of the time I find them undertreated. I most of the time see that the adult people don't dare to use as much drugs as you need to use and don't always understand the severity of the disease. I think that's an important message to remember. So how does the nephritis present? Well, a large group are nephrotic with substantial proteinuria and low serum albumin. And nearly all of the rest have proteinuria, but a lower degree. Macroscopic hematuria is very unusual. The children coming to you with macroscopic hematuria mostly, for example, have post-infectious glomerulonephritis, something like that. They don't normally have lupus nephritis. They have a little bit of impairment of the kidney function in many, but really severely impaired kidney function is unusual, in contrast to other even more acute cases of glomerulonephritis. So that they need acute dialysis or something, that is, you can see, very rare. So what's the prognosis of these children? I said it once, I would suggest that most of you sit on this side. I think you will feel more included, but it's up to you. I will turn my back to the rest of you. The mortality in lupus, there used to be three main causes. One was, of course, the renal failure. The other cause was an infection, and then some children, when they die from cerebral lupus or pulmonary lupus. Let's look a little bit more at the outcome. You can see this is really an old study, published 94, going back to children who had lupus nephritis very long ago. And you can see at that time, with 20-year follow-up, the survival of the children was some 80%. In a later cohort, but still long ago, you can see that seemed to have improved, and perhaps the 20-year would also have been more like 90%. Still, of course, a substantial percentage of children dying, and in many parts of the world is still clearly worse than that. This is a very, very complicated slide. I will try to explain it to you. This is developed countries. This is developing countries. And you can see here 5, 10, and 15-year survival. And this is going from 1970 to 2010. And you can see, I don't know exactly why that happened, but there is a tendency of improvement. But you can see even 2010, there is still too many children dying from lupus. How do we decide then to treat these children? Well, we like to have a kidney biopsy in a majority of cases, or in all cases. You remember that we use nowadays the ISN RPS classification going from 1 to 5. And to simplify, 1 to 4 is just worsening nephritis. 5 is a bad nephritis, but of different kind, of so-called membranous. And 3, 4, and 5 are those that we worry about and really treat aggressively, while class 1 and 2, we don't really treat from a renal point of view, even if those children always will need treatment for their lupus in other organs. Skip that, and this is what I just So how do we treat lupus nephritis? It's a relatively controversial topic. This is what I would call old treatment. You start with methylprednisolone. You start with a high dose of prednisolone orally, something like 60 milligrams or 80 milligrams per day. You give pulses of cyclophosphamide, and there are different protocols. Very many of us have used the old NIH protocol, which was 6 monthly pulses, originally for 24 months, but most, of course, used only for 6 months. And then, as maintenance treatment, these children were given azathioprine. I think this is still, in many places of the world, the most established treatment, and it's the one we've used for decades. Newer treatment is mycophenolate, rituximab, belimumab, and a large range of other drugs that are in trials or unfortunately have failed trials. So why do we need to change? Well, I hope I made that clear. The mortality is still clearly too high in lupus. And the side effect from the treatments we give is, of course, also substantial. You all know about cyclophosphamide side effects, immunosuppression with neutropenia, possible severe infection, a degree of hair loss, they don't feel very well. If we're unlucky and don't treat them well, they develop quite a severe cystitis. And there's this debated and partly unknown risk of later malignancy and infertility, which we hope, with the doses we've been using, is not a substantial problem. Could well be if we would use more of cyclophosphamide. Steroids, we use it a lot, of course, but we all know the Cushingoid fat, short child with hypertension, and with time, weakened bones. Of course, the psychological side effects are really substantial, as you know. I've seen a number of children becoming overtly psychotic. I had a girl who threw herself in front of a car in London as a suicide attempt because she was depressed by the steroids. The car managed not to hit her, but of course that's a very substantial and serious problem. So, if we go to the steroids now, how do we use them? The answer is we have no clue. Not a lot of studies telling us how much steroids. This is a study comparing a higher dose, perhaps a standard dose, with half that dose. And you can see in the outcome measures, no difference really. So most of us, many of us at least, nowadays would not use this kind of high dose prednisolone, but more of a starting dose of 30 milligram once daily. There's also been suggestions that you should do, like we do, for example, in some children with renal transplants, a steroid-free treatment. There's no studies. There was a study planned in England which failed because no one wanted to include patients in the end. But this is a retrospective case series from Western London. And they claim that not using steroids, but instead rituximab and mycophenolate was equally good. If we look at the results, though, quite interesting was that it was not very severely sick, much less unwell than the children we see. Only half of them double-stranded, only half of them low C3. So they treated a much less unwell group of children, or people we see. And the results were substantially less good than we prefer to have. A proportion really had high proteinuria at end of treatment, and a clear proportion was still nephrotic. And many of had quite bad kidney function. So in the adult world, this is hailed as a success. To me, in a child, that would be a failure. So if we go to mycophenolate mofetil, which is another new drug that's been used by us rather much of the last 15, 20 years. Many studies, the first ones are some 10, 15 years old. This is a meta-analysis comparing mycophenolate orally with cyclophosphamide IV. If you look here at mortality, end-stage kidney disease, renal remission, renal relapse, there were really no big difference between the treatments. Many people have said, okay, that's fine in the big group of children, but what about those with really severe disease? Do they not need cyclophosphamide? We can do this one first, apologize. This is side effects, difference between mycophenolate and cyclophosphamide. Of course, there was less ovarian failure with mycophenolate, less hair loss, less leukopenia, but as we know, a fair group of children treated with mycophenolate have stomach upset and diarrhea. And in those, of course, we might not be able to use it. But otherwise, with the severe side effects, cyclophosphamide did, of course, worse. Here's a slide seeing how did it work in those adults. All studies virtually I will show you are in adults because there are no good studies involving children. This is adults with low GFR. You remember normal GFR is 90 to 130. So this is very close to end-stage renal failure. And you can see these are those treated with mycophenolate, and these are those treated with cyclophosphamide. Small groups, I don't think you can say mycophenolate is better. There is clearly no data saying that you cannot use. You can equally well use, I think, mycophenolate even in the worst group. That was for induction treatment, that's for making these children well. The next part is, of course, the maintenance treatment. Here is a study that started off with 300-400 adult patients in induction, and then in the end came down to much lower numbers, comparing mycophenolate with azathioprine as long-term maintenance treatment. And this is the result. You can see there was a clear advantage continuing with mycophenolate instead of azathioprine. So most of us, I think, should now use both mycophenolate for induction and for maintenance treatment. And no data in children. This is something we published now 8 years ago. Our first children in where we used it. And you can see it worked well. This is an activity score in lupus. So, what more are the new drugs we use? Well, one is, of course, rituximab, which you know is a monoclonal antibody against CD20, which depletes B cells, which, of course, was used initially for B cell lymphoma some 25, 30 years ago. This is the first girl that I treated with rituximab for lupus. It was actually now 18 years ago, so we used it for quite a while. She was 13 years old, very severe lupus, needed to come to hospital twice a week to have albumin infusions. Responded extremely well to cyclosporine for a few years. Then that stopped. The effect of cyclosporine was no longer there, and her serum albumin was still very low. And we gave her rituximab, and she became nearly free of. And then I moved to London and we published a few case series. This is the second of 3 where we had 19 kids. And this is, I think, a brief summary of this very good science, but case series. Half of them made a full recovery, came to complete remission. 40% had an improvement, and one group, small group, had no effect. So what are the data? The data, unfortunately, are much less encouraging. There's only one study on lupus nephritis. That's, of course, again in adults, called the LUNAR study. Fairly small to be an adult study. Most adult lupus studies are like 500 or 1,000 patients. So fairly small, 52-week follow-up. And here's the result. It was a comparison between mycophenolate plus placebo and mycophenolate plus rituximab. The results, I think, clearest here that this is those who did not respond, and you can see those here with placebo did worse. The difference in 11% was not statistically significant. So in the only really scientific study, strangely enough, rituximab did not seem to work. And this came some, I think, 8-9 years ago now, and everyone scratched their heads and said, why could this be the case? Doesn't fit with what we think we know. And there are many explanations. It's very, very difficult to define outcome in lupus. There are some studies, and we'll come to that in other drugs, that have been effective. They show very much the same improvement, some 11-12%. But they have had much bigger studies, and there could be other reasons. One reason is that these adults were actually not so bad. So most of them would never normally have had rituximab in my book. So, of course, if you treat someone who doesn't really need it, you won't get such a good effect. But if you looked at biochemical markers like double-stranded DNA, was clear improvement compared to placebo, but not statistically significant. This is very interesting. We, of course, still, even if I've used it for 18 years, worried about the long-term side effects by rituximab. This is what in this randomized, blinded study, how were the serious adverse events? They were actually more common in the placebo group, which of course can't be true. It's not a possibility that placebo gives you more side effects. And what that tells you is, of course, that it's hugely difficult to define what's a side effect, what's actually a lupus symptom, because they can have so widespread lupus symptoms. But it's still, of course, encouraging that it was not worse in the rituximab group. What was worse was, of course, that there are some patients who get infusion reactions. We know that, and we have to reduce the dose when we give it. Still, a fair amount who had infusion reactions to placebo. But that's, of course, very believable that you will get more infusion reactions from the active drug. And this is what we already talked about. Why did it not work in the study? Everyone got disappointed, of course, but everyone felt, I have so many patients where it worked. The study doesn't agree with that. What do I do? So the adult put together, not a very big, but still a cohort around Europe of 164 adult patients. They published that now 7 years ago. They found that 30 had a full response, a third had a partial response, and a third no response. And that sort of allowed us to continue to use it, albeit it's not registered for lupus. So it's not formally a lupus drug. This drug, however, is the only new formally used lupus drug, Belimumab. It works in some ways rather similarly as rituximab. It attacks a cytokine that modulates B cell survival. So it attacks also, influences the B cells. They made you can see much larger studies, approaching 2,000 patients. They had very complicated outcomes. And you can see what was the difference between the highest dose group and the placebo group. Well, you remember it was 11% in rituximab. It was 12% in this study, which of course is not different. But if you have 1,500 plus patients instead of 150 patients, then of course this becomes significant. This is now scientifically proved to work, and with that registered as a lupus drug. It's not used as much as the company would love us to. I think most people continue to use rituximab, but it's still an important drug out there that perhaps is underused just now. So what next? This is a list that I took from a paper, and it's clearly not all. You can see numerous of antibodies attacking numerous targets in the immune system. And the drug companies have spent so much money on this, where these are mainly studies, often in 500 or 1,000 patients, and virtually all of these have failed. So there's been a large work finding new lupus drugs in many patients. It's been difficult to find patients for them because virtually all, so many drugs and so many studies. But so far, it hasn't really given us the results that we've been hoping for. But there is a little bit of light on the horizon. These are these Janus kinase, JAK inhibitors. If you read the literature, it started to being used in more and more different or autoimmune diseases. And you can see this is a public study published in the Lancet this year, and this in different ways. I only showed you this slide. I think it was phase 2 study, if I'm not wrong. So it's clearly not out there for the market, but at the present, this is the one that gives us some hope that we will have more drugs to use in the children that really need that. So, how do I summarize that for myself? How should we do it? We should always do a kidney biopsy to see that it has bad enough lupus nephritis to treat. Don't delay treatment. We should always aim for a full renal response. As I said, if too many adult rheumatologists are involved, that will not always happen. They need very long-term treatment, maintenance treatment. We really don't know how long or when we can stop the treatment. How do we do it? We use methylpred to kickstart it. We start in our unit with about 30 milligrams of prednisolone that we try to come down with. I think many of these girls have had so much bad side effects. I find that psychologically very important because we treat group of children that really don't like treatment. Young teenage girls. And they get so ugly side effects. And we still want them to continue to treat. And I think there is a big balance between having a good trust from them in us and getting a good response. So I think this is really important. We don't make too much harm with prednisolone. Still, we need the steroids to get the start. We nowadays use rituximab in virtually all cases as start, and we start with a high dose of mycophenolate. in those few very severe cases, we might use plasma exchange. How should we do maintenance treatment? Low dose or perhaps no dose of steroids, a good dose of mycophenolate, perhaps a dose of hydroxychloroquine. There is clearly a group of girls and boys, even if of course mainly girls, need regular rituximab, which could mean that they have it once every 9 months, once every 12 months. And I think there's several reasons for this. One might be that they are not responding to mycophenolate as much as they should. But one other, I think, is because rather many of them actually don't take their drugs despite what we do. And if they got this kind of disease, of course, we see the results of that very quickly. And if we give them yearly rituximab, then we can keep them quite well in a majority of cases because the drug will be on board. Yeah,